Okay, it's a little bit past 12:30, so I think we should go ahead and get started. This is our annual session. We have this session every year in June. As our fellows are graduating, we have them present on their research projects and their quality assurance projects over the previous year. So this year, I'm very pleased to introduce our 2019-20 Geriatric Medicine Fellows. All 5 of our fellows will be participating in this presentation. So the first fellow is Dr. Savitri Aguiar, and he was originally from Brazil, then did a residency in internal medicine and is now currently finishing a geriatric medicine fellowship. Our next fellow is Dr. Lauren Ando. She's from the John A. Burns School of Medicine. She graduated from there, did family medicine residency, also here in Hawaii, and is actually going to be staying on for a second year of fellowship training. So we will have Lauren for 1 more year. Our third fellow is Dr. Marina Hitasugi Levesque, also a JABSOM grad. She completed internal medicine training on the mainland and then came back home to do her geriatric medicine fellowship and is going to stay in Hawaii after. The next fellow is Dr. Jennifer Nakamatsu, another JABSOM grad who did internal medicine training here in Hawaii, is now doing geriatrics, and then after graduation is also planning to stay on in Hawaii. Our last fellow is Dr. Neela Soy, and she's originally from Myanmar, where she went to medical school. After that, she did an internal medicine residency on the mainland in New York, and then came here to Hawaii for our fellowship program. So I'm really pleased to introduce all of our 5 fellows. They've worked very hard on these projects, and we appreciate the faculty support. I noticed many of the faculty have joined in, so we appreciate your support. I do want to say that none of the presenters have any conflicts of interest with financial entities. Okay, the first presenter is going to be Dr. Savitri Aguiar, who's going to be presenting his research project. Savitri, do you want to use your share screen, please?
Okay. I'm trying here, view options. I'm just viewing JABSOM Zoom 20 screen. I don't know how to do that. I don't see that menu here.
Oh, Savitri, hover over the bottom of the black part of the screen and it should hopefully pop up for you. And then it's the middle.
Oh, okay, saw it, okay. Okay.
Everyone who wants CME attendance, could you please type your name into the chat box so that we can keep track of who's attended and give you continuing medical education credits?
Okay.
Wonderful. So Savitri, you can start your presentation now.
Okay, so good afternoon, everybody. I'm going to talk about this research project we did entitled Loneliness and Depressive Symptoms and 28-year Mortality in Older Japanese American Men, the Kuakini Honolulu Heart Program. This was presented as well at the ACP meeting and had been accepted for oral presentation at AGS that was canceled in May in Long Beach. So I thank you very much to all the faculty that participated in this project, especially special thanks to Dr. Masaki. So the most important thing is to reiterate what Dr. Masaki has already said, that the investigators retain full independence in the conduct of this research. So in the last century, there have been major changes in social structures. And one of the unintended consequences in the way we live, society at large, has been an increase in loneliness for many, many reasons. Previous studies on loneliness and depression as predictors of mortality have had mixed findings. And most studies included either loneliness or depression, but not both. And most were in white populations. So we studied whether loneliness and depressive symptoms predicted all-cause mortality over 28 years follow-up in a cohort of older Japanese American men in Hawaii. This is a study based on data from the Kuakini Honolulu Heart Program, which is, as probably everybody in this room knows, but if you don't, it's a population-based longitudinal cohort study since 1965. It's a cohort of Japanese American men on Oahu, Hawaii, of ages between 45 to 68 at the study enrollment. They have been followed up for all mortality and selected morbidity since the start of the cohort. The baseline for this particular analysis was the exam number 4 that happened between 1991 and 1993. We had 3,741 men of ages between 71 and 93, but we have excluded some. So our analytic sample was of 3,186. We excluded men living in nursing homes, a total 67. We excluded 486 participants that didn't have a valid depression screen, and 2 that didn't have answer to the loneliness question. We chose to perform this analysis in community living men. So that's why we excluded nursing homes. So the predictor variables, we were looking at depressive symptoms and loneliness. So it's important to separate depressive symptoms from depression. We didn't have a diagnosis of depression. We used the Center for Epidemiological Studies Depression 11-item scale questionnaire. And those 11 questions about feelings and behaviors in the past week, so a week before the interview, and each question was scored between 0 and 3 points with a total score ranging from 0 to 33. A score of 9 or higher is clinically significant. So with that being said, we had depressive symptoms present in 314 out of our analytic sample, giving us about 10% of those men had that. And loneliness was a single self-reported question that said, I felt lonely in the past week. And 11.7% or 372 out of 3,186 men had answered yes to that. So we also created a 4-level predictor variable. We separated in 4 categories: the ones that did not have loneliness or depressive symptoms, and those were about 84%. Then we look at the ones, another category of the ones that had depressive symptoms but didn't have any loneliness, and you can see the percentage of 4.5. The third category was the ones without depressive symptoms but with loneliness, about 6.4%. And finally, the last category, category 4, that they had both. They had both depressive symptoms and loneliness. And that gave us 169 participants, which is about 5.3%. So the outcome variables. So to look at mortality. So we have a comprehensive surveillance system for all-cause mortality since 1965. The records from hospital discharges on Oahu, obituaries, death certificates, and medical examiner's office. Also, a surveillance for all-cause mortality has been essentially complete, and the mortality data was available through December 2018. So that is about 28 years of follow-up. As covariates, we had age, cardiovascular disease risk factors, including BMI, physical activity index, smoking in pack years, total cholesterol level, hypertension, diabetes, also some prevalent diseases like heart disease, stroke, cancer, emphysema, Parkinson's disease. Another covariate was a functional impairment, as defined by inability to walk half a mile, and the presence of cognitive impairment or dementia. So the statistical analysis. All analyses were done separately for the following predictors: depressive symptoms, yes or no; loneliness, yes or no, and for the 4 category variable for depressive symptoms and loneliness that I just mentioned a few slides before, those 4 combinations, possible combinations. We had age-adjusted mortality rates, Kaplan-Meier survival curves for all-cause mortality, and a multivariate Cox regression to calculate relative risk for mortality. So in this slide, we have the age-adjusted mortality rates. We are comparing depressive symptoms and loneliness. And the gray is no, the red yes. So you can see the age-adjusted mortality rates per 1,000 person years follow-up, and the p-values are significant, more so for loneliness. But this is when you look, I'm sorry, every time I move the cursor, yeah, that gray bar shows up. So for loneliness, more so, as you can see. This is the age-adjusted mortality rate for the 4-level predictor variable. So we see a kind of a cumulative effect, and as you go from neither, the lighter blue bar, to depressive symptoms only, loneliness only, but more so for both. And we have the P calculated for this trend, very significant, as you can see. So this is a Kaplan-Meier survival curve. The x-axis has time in years of follow-up. At the top left, we start out with 100% of the population. The lines separate and show that those without depressive symptoms clearly die at a slower rate, with the most separation at about 10 to 15 years of follow-up. This is the Kaplan-Meier survival curve for loneliness, which shows even more separation between those with and without loneliness. This here is the Kaplan-Meier survival curve for the 4-level variable. Those with neither is the red line, which clearly shows the longest survival. The black line is for those with both depressive symptoms and loneliness, which shows the shorter survival. Among the other 2 groups, in general, those with loneliness show higher mortality than those with depressive symptoms. We use Cox regression to calculate the relative risk for mortality, unadjusted and fully adjusted for all covariates. These columns show the relative risk for each model with 95% confidence intervals and p-values. For depressive symptoms, the unadjusted model showed a 19% increase in risk for mortality, which was statistically significant. However, fully adjusted model was no longer significant. For loneliness, the relative risk for mortality was around 1.3 and significant for both unadjusted and fully adjusted models. This means that those with loneliness have a 30% higher risk of mortality. For the 4-level predictor variable, the reference group was those with neither depressive symptoms nor loneliness. In the fully adjusted model, oh, what happened? I'm sorry. Where did it go? Are you guys still seeing my screen? Resume?
We can still see
Okay.
it.
Oh, okay, sorry. For my computer here popped up something. So what I was saying is that this is the reference that for the 4-level predictor variable, the reference group was those with neither depressive symptoms nor loneliness. In the fully adjusted model, depressive symptoms were not significantly associated with mortality. However, those with either loneliness or both depressive symptoms plus loneliness had a 27 increase in risk of mortality, and both were statistically significant. In conclusion, loneliness, whether on its own or in association with depressive symptoms, was a significant independent risk factor for 28-year mortality in older Japanese American men in Hawaii. Our results highlight the importance of social relationship in older people. The strengths of this study was a long follow-up, about 3 decades, a large sample size, a population-based study, excellent retention rates, and very little loss to follow up. surveillances for mortality essentially complete, and unique population of Japanese American men. On the limitations, we have a limited ability to generalize because it included only older Japanese American males. This is also an observational study, so one cannot assume causality. Loneliness was a single question at one point in time. So that is also a very important limitation. That one may think, what if the person would change that in a week, a month, a year, whatever. And the depressive symptoms from a single point in time as well. So future directions, other longitudinal cohort studies in different ethnic groups could be done, in different age groups and in women. And a possible clinical trial of social interventions to see if there is an effect on mortality. Thank you.
Thank you, Savitri. That was an excellent presentation. Just to let everyone know, I think Savitri mentioned it, but some of you might have missed it. He did do an oral presentation at the Hawaii Chapter American College of Physicians conference in February and was selected for an oral presentation at the National American Geriatric Society conference, which unfortunately was canceled because of COVID. If there are any questions right now for Savitri before we go on to our next presentation, could you please type in the chat box? Oh, I see one already. So, Savitri, this is a question from about, can you comment on whether people with loneliness were also living alone?
Okay. We have another part here, another piece of data about the living alone. It's important to highlight that those are different things, and we are looking at loneliness. Living alone does not necessarily mean loneliness. It's a totally different thing. So we're talking more about social support. This is not what we were looking at, but this subjective feeling of loneliness that is defined as the discrepancy between what one wants in terms of social relationship and what one gets. So that's what I have to say.
Okay, thank you. There's another question, another comment and question. Great work, congratulations. Prevalence of depression in this study seems very low, about 10%. Can you comment on the sensitivity and specificity of the depression questionnaire?
I am not aware of the sensitivity and specificity of that particular questionnaire, so I can't answer that.
I can comment a little bit on that. So the CES-D, the full scale is a 20-item questionnaire, and it's been well validated in multiple different populations and has, I can't give you the exact sensitivity and specificity numbers off the top of my head, but it is a well validated questionnaire. It hasn't specifically been validated in this particular population, but I suspect that it does have good sensitivity and specificity. And the reason I say that, it's been proven to be a pretty robust predictor variable for many different outcomes. And actually for community dwelling elders, 10% is not, it's not a very unusual number. And we particularly picked community dwelling elders for this. I think when you look at the older population in the hospital, and nursing rates tend to be much higher. Okay, one other comment and question. Thank you for a very clear presentation. Surprised by the findings that loneliness seemed to be a stronger predictor than depression for more.
Yeah, so this is a fascinating topic. I also got very interested in this and read. I went to GSA meeting in Austin. So I was lucky because I was one of the fellows that chose to go to GSA in November. And I was in some groups there, discussion, that this topic of loneliness, it's absurd. It's like people, not only in the elderly, but the entire population. So it's more prevalent than in the elderly, but it correlates. People are coming up with numbers that compare to chronic diseases, to obesity, in terms of prediction of mortality. So when I was reading about that, so I didn't get surprised by Dr. Dr. Fishberg, I think he's asking about if I was surprised about the loneliness, more strong predictor than depression. No, I wasn't.
Thank you, Savitri. There is one other comment. Dr. Wen was asking about living alone as a confounder. Actually, we did look at that in a separate analysis, which is not reported here, Aida. Surprisingly, living alone itself was not as strong a predictor as the loneliness feature. And when we adjusted for living alone, we adjusted for marital status, we adjusted for a bunch of different things, it did not change the effect of the association between loneliness and mortality. So I hope that answers that question. Okay, let's go on then to our next presenter. Marina, would you bring up your slides, please, while I introduce you? So Dr. Hitosugi Levesque, Marina Hitosugi Levesque is our next presenter. She will talk about her research project. She also presented an oral presentation at the Hawaii chapter of the American College of Physicians and actually won an award for Best Fellow Project. And she was also for the presidential poster session for her project. So go ahead, Marina.
Thank you, Dr. Masaki. I'm just going to use this view because this way I can still see my notes. I can't do the usual PowerPoint view. So my project was similar to Savitri's, so please bear with me. I focused on depressive symptoms, predicting 6-year incident disability in older Japanese American men, also using the Kuakini Honolulu Asia Aging Study. I'd like to acknowledge all my co-authors and supporters for this research, and I'd like to thank everybody for being here today. As we know, depressive symptoms in community-dwelling older adults have been associated with increased frailty and functional decline, although most previous studies have been done in mostly white populations. Depressive symptoms in older Japanese American men have been associated with decline in hand grip strength, but the effect on activities of daily living have not yet been examined. So we wanted to study whether depressive symptoms in older Japanese American men predicted future disability in activities of daily living and instrumental activities of daily living over 10 years of follow-up. I also use the Kuakini Honolulu Heart Program, which has been compared to a Japanese American Framingham study, and it is still ongoing. With Dr. Masaki told me the last count of survivors was 40. It was started in 1965. So it's a pretty specific population of Japanese American men on Oahu. This cohort was selected from World War II selective service registration. At baseline, the men were 45 to 68 years old. At the baseline for this analysis, we used exam 4, which was from 1991 to 1993. And this was the start of the Kuakini Honolulu Asia Aging Study, which was to focus on aging and disability. And this included 3,741 men, or 80% of the original study. And they were 71 to 93 years old. Our exclusion criteria were those without a valid CES-D 11 depression questionnaire, which was 545 people, and those with baseline activities of daily living impairment, which was 170 people. So we had a total analytic sample of 3,026 men. Just to comment on why there were so many without a valid CES-D 11, it's because they had to, they were excluded if they couldn't answer 3 or more questions. And some of those participants that had cognitive impairment couldn't have a proxy answer for them like they could for a functional questionnaire. And then just to let you know, about 1% of this baseline population was on an antidepressant. And as Dr. Masaki had just mentioned, about 10% of the population was considered to be depressed. So our predictor variable was depressive symptoms based on this CES-D 11 scale. This is the shortened version of a 20-item scale. I just did a quick Google search for the sensitivity and specificity of the CES-D 11, and there's kind of a lot of numbers out there, but they're mostly for the CES-D 20, and it looks like the sensitivity is about 80%. So the CES-D 11 has 11 questions about frequency of feelings and behaviors over the past week. So this is really just one point in time. And then each question was scored 0 to 3 for a total of 33 points. And a score of 9 or higher was clinically significant. And this had previously been validated as a cutoff point. And so depressive symptoms were present in 9% of over 3,000 men. Yeah, as I mentioned, we're only looking at symptoms at one point in time, so this was not the same as diagnosing for clinical depression. Since this was a very large cohort study, the CES-D 11 was more practical than getting a DSM diagnosis for each participant. Our outcome variable was incident disability. So incident functional impairment or new functional impairment categorized by self-reported deficits in either basic activities of daily living or instrumental activities of daily living, or either of those two. And we compared development of new functional impairment over 3, 6, and 10 years of follow-up amongst those with and without depressive symptoms. I'm sure most of you are already familiar with how to define activities of daily living, but we looked at both basic and instrumental ADLs. So for the basic ADL definition, we used a 6-item questionnaire that focused on basic self-care tasks, such as getting around the house, transferring, feeding, dressing, bathing, and getting to or using the bathroom. For instrumental ADLs, this 5-item questionnaire was kind of titled home management. So tasks that used more complex thinking and organization, like housekeeping, shopping, meal preparation, managing money, and using the telephone. Our baseline covariates were age, education, many cardiovascular risk factors, prevalent chronic diseases like coronary heart disease, stroke, cancer, emphysema, arthritis, and Parkinson's, as well as cognitive impairment or dementia. And these were the factors that were used to adjust for potential confounding. For statistical analysis, we used general linear models for baseline mean risk factor levels by either presence or absence of depressive symptoms, and this was all adjusted for age. Multivariate logistic regression was used for odds ratios of incident functional impairment by presence or absence of depressive symptoms too, and separately at 3, 6, and 10 years of follow-up. Now going on to results. The baseline mean risk factors by depressive symptoms. So people with depressive symptoms tended to have a lower BMI, higher rates of emphysema, and higher rates of cognitive impairment. I'm not completely clear about why the emphysema and not any of the other chronic conditions that were listed here at the bottom of the table. But cognitive impairment and lower BMI, you know, for those of us that work in this field is not too surprising. So looking at incident basic ADL impairment by depressive symptoms at 3 and 6 years. So the blue column here is for those that did have depressive symptoms, and the orange column is for those that did not have depressive symptoms. And you can see that there was a higher rate of incident basic ADL impairment at both 3 years and 6 years of follow-up, higher in the depressive group. And similarly, for the incident instrumental ADL impairment, there was a higher rate at both 3 and 6 years for those that had depressive symptoms. And all of these were statistically significant. And when you combine the two, looking at either basic ADL or IADL impairment, unsurprisingly, there was a higher rate in the depressive symptom group here as well. So Our odds ratio was more than double the risk of having incident ADL impairment if you were in the depressive symptom group. And yeah, more effect at the 3-year compared to the 6-year follow-up. And again, for the instrumental ADL impairment, there was 1.6 odds ratio for 3 years and 1.4 for 6 years. And almost 2 times the risk if you had either basic ADL or IADL, and 1.5 times the risk if you were 6 years follow-up if you had depressive symptoms. So to summarize all of that, in older Japanese American men with functional impairment, without functional impairment in ADLs at baseline, depressive symptoms independently predicted incident impairment in basic ADLs and IADLs at 3 and 6 years of follow-up. The reason none of those prior slides had the 10 years of follow-up was because there was no significant effect at 10 years of follow-up. And it's likely because by the time that they got to 10 years of follow-up, there are probably bigger factors going on that impacted their functional status more than depressive symptoms. The strengths of the study is that it's the first study in older Japanese American men to examine the association between depressive symptoms and functional impairment as measured by ADLs or IADLs. And it's a very large sample size with a long duration of follow-up, and we had really good surveillance system for outcomes. However, the limitations are that this is an observational study, so we're unable to imply causality. And since we have a pretty specific population that we're looking at here, it's limited in its generalizability. And it's also unclear which subjects may have been started on therapy for depression or related symptoms anywhere in those years of follow-up. And so, for example, they may have reported depressive symptoms and at some point was started on antidepressants and then maybe discontinued off of it, or the reverse. So we have no way of really knowing. Functional status was also by self-report or self-report by proxy. And of course, anything that's self-report is going to be somewhat subjective. The clinical implications for this are that screening for depressive symptoms in geriatric patients can help clinicians identify patients at higher risk of future functional decline. And this, I would say, is also in the bigger context of depression in older adults being under-recognized and undertreated. And positive screenings can provide a platform to discuss therapeutic interventions and provide anticipatory guidance for patients and their caregivers. And that's it. Any questions? Here are the CES-D 11 questions.
Thank you, Marina, for an excellent presentation. So everyone, if you could please type in your chat box if you have any questions for Marina. And while I'm waiting for the comments, I just wanted to give a lot of credit to the Honolulu Heart Program staff at Kuakini, because they've done an amazing job with this project over many decades. Some of our staff have been with the program for like 35 years or more. So it's pretty amazing. Any questions at all for Marina? Please type in the chat box. Okay, no questions at all.
Thank you.
Yeah, okay. All right, we'll move on then to our last presentation. This is our quality improvement project that we annually have all fellows participate in. So all 5 fellows are part of this, but the remaining 3 fellows are going to share the presentation. So I'm going to hand it off to Dr. Soy, who is the first presenter. Neela, could you introduce the topic and what you did?
Hi, my name is Dr. So, Neela So. I'm a geriatric fellow. We were present with this QAPI project that we continue the last year fellow project. I will present the introduction and objective and also background history. And other fellows are Lawrence and Jennifer will present the other parts. Sorry, John, can you please move back to the previous slide? So our QAPI project is medication reconciliation during hospital to nursing home transition. Next slide, please. I would like to acknowledge other co-fellows and our faculty to complete this QAPI project for this year. And we are finding sources from the John A. Hartford Foundation Center of Excellence in Geriatric, Jepsen, University of Hawaii, and Geriatric Workforce Enhancement Program. We have no conflict of interest to declare. Next slide, please, John. So the federal government requires nursing home to have a QAPI program according to the Affordable Care Act. And we found out that there is a readmission rates to the hospital within 30 days are high. It almost 1/5, 19.6% of all medical beneficiaries are re-hospitalized within 30 days in 2004. That cost estimated 17.4 billion. So, and also there is a studies have found that information on discharge summaries and transfer form does not match for over 50% on nursing home admissions, including SNF and long-term care facility, with at least one medication discrepancy in 70% of all admission. I just Googled it and found out that in 2016 April, there is a research study found out this data, that's over 50% on nursing home admission does not match with the discharge summary and transfer form. Yeah. Next slide, please. So background, so this QAPI project is required for licensing of nursing home and accreditation of graduate medical education programs. Our project is the continuation of the 2018 to 2019 Medication Reconciliation Fellow Project. What we do this year is that we collaborate with nursing home leadership to design and assess an intervention such as training. We provide the training and changes in the admission process for our purposes for reducing medication errors during the transition from the hospital to nursing home. Next, please. So our study methods consists of 3 phases. Phase 1 is baseline data. That was done from July to October 2018. And PBS fellows and faculty collected the 16 SNF admission documents, and they review and coded, including 5 different sources of information about medications that are sent from the hospital to SNF. Those are hospital discharge summary medication list, hospital discharge summary notes, hospital discharge order form, hospital medication administration record, MAR, and written patient's instruction. And also they quoted the 5 different aspects of admission medications. These are total number of medications per patient, number of medications which needing clarification, and number of medication that miss an indication. And also they quoted for potentially serious medication errors that could have happened, and also common classification of medications with error. Then we move on to phase 2. Next slide, please. In this year, in this our fellowship training last year, October to December 2019, we implemented the phase 2 intervention. We perform the intervention such as we provide the training of internal medicine residents on their inpatient rotation during November and December in 2019. We provide the training on how to write a discharge summary and how to make the discharge orders. At the SNF side, we work with the director of nursing to adjust the admission process, to utilize checklists, and also we standardize the training of floor nurse by supervisor. So this study is done in the, just one community nursing home in Honolulu. And then we can move on the phase 3 follow-up. Can you please move to next slide, please? So phase 3 follow-up data that was implemented in this year, January to February, we fellow and faculty review the chart of 24 SNF admission. We use the similar method that I mentioned in the previous slide and those used in the 2018. For data analysis, we use descriptive statistics. We use mean, standard deviation, percent, and range. For compared to difference between the year 1 and year 2, we use t-test. So our next portion, the result will be presented by Lauren and Du.
Hello, I'm Lauren. So I'll just be presenting or going over the collected results over the 2 years that the data was collected. So July to October 2018 and January to February 2020 will be descriptive. So yes, on this slide, on an average admission, patients were prescribed about 12.1 medications per admission, which is seen on the far left of the screen. So 12.1 medications per admission on average, while half of those medications would needed clarification in dose or frequency or holding parameters. On an average admission, about half of those medications also needed an indication, which is the 6.7 you see in the middle. And we do need to write those indications in order to prescribe any medications in the nursing home. So if they didn't come with one, we have to provide one. On average, also, there was a low amount of potentially serious medication errors at 1.7, while only 0.8, so a little, definitely less, actual medication errors occurred. On the next slide, next slide, please, John. Yep, that one. Okay. So of all the admissions evaluated, only 2.5% of the admissions had no issues with their medication reconciliation. That's on the far left on the bottom. 12.5% did not need a clarification in usually dosing or frequency or hold parameters, since the indications was in a separate data set. So the 15% already had complete indications, and 45% did not have potentially serious errors. On the next slide, thank you. Of the patient admissions with medication problems, this is a breakdown of the problems by drug class. On the far left, you can see that the bowel medications needed the most clarification because it's not unusual that we need a bowel regimen. We definitely need it. So we either ordered it in the nursing home, added it on, adjusted it upon admission. It's not surprising. And then thereafter, other common classes would be the cardiac medications, antibiotics, aspirin, Tylenol, opiates, pain medications. Next slide, please. The most common medication error types included medication dosing, as seen on the far left. Following that would be missing medications or inconsistent medications. That means a medication might be listed on the MAR of the hospital that is printed out for us, but not necessarily in the discharge summary or discharge medication list. So we'd have to kind of reconcile those. And then thereafter, hold parameters would be needed, especially since our very frail and elderly population do need those hold parameters for their blood pressures and heart rates, and if they have loose stools for bowels. Another medication errors included the indications and frequency. Next slide. So that concludes my section. Next, I'll hand it off to the amazing Dr. Jen Nakamatsu for the results.
Let's not raise expectations, Ando.
Oh, well.
So I'm Jennifer Nakamatsu. I'm one of the fellows as well. I will be going over the results for comparing the first and second year of the study. So this first slide just talks about the medications per patient by year. So as you can see, both year 1 and year 2, the average number of medications was roughly the same, about 11 to 12 medications per patient. Next slide, please. Oh, thank you. So this next slide, we talk about medications needing clarification by year. And we can see that from year 1 to year 2, after some interventions, the amount of medications needing clarification reduced by almost half, and it was p-value was significant. Again, we see that the mean number of medications missing indications from the first year to the second year again decreased by half again, and the p-value was again significant, showing a significant decrease. For this slide, we looked at the number of potentially serious errors for each patient. In year 1, it was 1.7, and in year 2 is 0.8. We did see a downward trend in the number of serious errors. However, it was not statistically significant from year 1 to year 2. So in conclusion, we were able to successfully implement a QAPI project on medication reconciliation in a community skilled nursing facility. We achieved our goal of conducting a needs assessment, collecting and analyzing data, as well as collaborating with the nursing home and hospital leadership and staff to obtain that goal. When we compare the 2018 to 19 to the year 19 to 20, we did see significant improvements in the number of medications needing clarification, as well as those needing indications. And then again, although we didn't see a statistically significant difference in the amount of serious errors, it was downtrending. And given the small number of patients we were able to pool, it's not surprising that we couldn't get a statistical significance. Next slide. So some of the strengths of our study is that by doing this study, we were helping to fulfill the licensing needs of nursing homes, as well as their accreditation needs for our fellowship program. The interventions that were done did seem to show improvement in some of the areas, specifically the 2 that we talked about. And we were able to collaborate with leadership and IDT members with the goal to improve patient care. Some of the limitations that we saw with the study is that the data collection forms that we were used were not validated tools. And then convenience of sampling of a small population limited the power for the study. So we hope to continue collaboration between staff in both the hospital and nursing home setting to streamline the process to minimize medication errors in order to encourage a safer transition of care for all our patients. We hope to foster champions within both nursing home and hospital to help model change for the future. And then one area of study we hope that this study could potentially go to is to study the transition from nursing home to home, although there are many challenges that would probably arise when doing that study. I believe that's the last slide. Yes, so thank you so much for your time, guys.
Thank you, all 3 fellows, in fact, all 5 fellows for wonderful presentations. Does anyone have any questions about, oh, here, I do see a couple of, okay. So there was one comment, great presentations, Jerry fellows, thank you. And there's a question, can you talk a little bit more about the intervention? What did the training look like?
So for the training, we provide the training to internal medicine residents from the hospital who are at the time who are working in the inpatients rotation. So we provide the training for those internal medicine residents for how to write discharge summary and how to place the discharge order of all of these, medication, discharge medication list. Yeah. So because according to the previous study, we found out that there is some medication discrepancy, including dose and indication, missing data in the between the discharge summary and discharge medications order. So we try to find out that any errors between the transition from the hospital to nursing home. So that's why we divided the two sessions. One is for the training to the hospital side, and other side in the nursing home. We collaborated with the nursing home supervisors and other administrators to provide the training to the nurse, and how do we evaluate the discharge summary from the hospital, how do we communicate with the hospital, so that's how we train for that. That is for our intervention. Yeah.
Thank you very much, Neela. I did have something to add to that as well. What we found is that the hospitalists, one of the hospitalists told us this. What they didn't realize is that there wasn't a physician waiting at the nursing home to admit the patient. Like they almost thought it would be like an ICU, where there's somebody waiting at the door. And we had to kind of train them that the physician may not even see the patient for 24, 48, even sometimes a little bit longer. So what you need to do is you need to write your discharge orders like you are the physician taking over the patient. One of the hospitalists suggested that we train that way. That's what we did with the residents, and we found that that improved things very much. Okay. I'm not sure I understand the question from Brad. So I'm going to pass over that because I don't think the fellows will be able to answer that. So Brad, we can answer that later. Any other questions for the fellows for their QAPI project? Okay, if not, anybody want to type in the comment section? Chat box? If not, I thank everyone for wonderful presentations. Fellows, you did a great job. And thank you to the faculty and others who joined in today to support our fellows. Okay, bye-bye, everyone.